Hi, y'all, and welcome back to Professor Truelove's Concepts for Nurses series. And in this episode, we will discuss the care, assessment, and maintenance of patients suffering from cerebral hematomas. Our sources for today's presentation include Iggie's Medical Surgical Nursing 9th edition and Sol's Introduction to Critical Care Nursing 7th edition. One type of cerebral hematoma is known as an epidural hematoma. This is when blood is found between the dura and the skull. It is frequently associated with a linear fracture of the temporal bone, and it results from the tearing of the middle meningeal artery. An epidural hematoma is a neurosurgical emergency. Arterial blood accumulates rapidly in the space in minutes to hours, that is, usually within the first 24 to 48 hours. One of the ways to see this is that the pupil on the side of the lesion becomes fixed and dilated. Other things to look for when assessing for an epidural hematoma include a short period of loss of consciousness, then a period of lucidity, then neurologic deterioration. The period of lucidity can last for a few hours and as long as 48 hours. However, as the patient continues to deteriorate, the level of consciousness decreases. Contralateral deficits begin to appear, and the pupil on the side of the lesion becomes fixed and dilated. There is also an association with irritability, headache, and motor and cranial nerve dysfunction. A subdural hematoma. This is because of venous bleeding into the space between the dura but above the arachnoid. It is most commonly caused from tearing of bridging veins within the cerebral hemispheres or from laceration of brain tissue. The bleeding occurs more slowly, and therefore the symptoms may mirror those of an epidural hematoma. There are three types of subdural hematoma: acute, subacute, and chronic. In all three, there is blood within the subdural space that may be bilateral and is usually from a torn cortical vein. An acute subdural hematoma occurs within 48 hours of the injury, is seen mostly in deceleration injuries, and is associated with contusions. There is a higher risk of death because of injury to the brain tissue and the mass effect caused by an expanding hematoma. Therefore, surgical intervention occurring within 4 hours of injury improves mortality. A subacute subdural hematoma occurs within 2 days to 2 weeks after the injury, and in this case, the onset of symptoms is slower and more subtle. The onset of symptoms is later because of the normal compensatory mechanisms, which promote continuous brain function as the hematoma slowly grows. For both acute and subacute subdural hematoma, the nurse should look for signs and symptoms such as depressed or changed level of consciousness, pupil and extraocular movement changes, motor changes, and complaints of a headache. Chronic subdural hematomas occur as a result of low velocity injuries. And remember, symptoms can occur up to 2 weeks to several months after an injury. A higher incidence of chronic subdural hematomas is seen in the elderly, with chronic alcohol abusers, or those taking anticoagulants, including Coumadin, Plavix, or aspirin. Because the symptoms are often subtle, the diagnosis of chronic subdural hematoma is often missed. These signs and symptoms may include personality changes or problems with the gait. An intracerebral hematoma is a large hemorrhage into brain tissue that creates a mass lesion. It may occur from trauma, ruptured aneurysm, AVM, vascular tumor, or ruptured vessels from a history of hypertension. These have varied signs and symptoms depending on the location of the bleed. It is important to remember that the small ones may resolve, but that the large ones may require surgical excision. A subarachnoid hemorrhage, or SAH, is the most common type of intracerebral hemorrhage. It may act as a space-occupying lesion and may be potentially devastating depending on its location. ICH itself may also produce significant brain edema, causing increased intracranial pressure. A brainstem hemorrhage occurs as a result of direct trauma, fractures, or torsion injuries to the brainstem. And although symptoms of intracranial hematoma may not be immediately apparent, the nurse should watch closely for subsequent physical, mental, and emotional changes, because an intracranial hematoma is potentially life-threatening and often requires immediate treatment. These signs and symptoms may include an increasing headache, vomiting, drowsiness and progressive loss of consciousness, dizziness, confusion, unequal pupil size, weak limbs on one side of the body, and increased blood pressure. An intracranial hematoma often requires surgery to remove the blood clot. However, remember, a smaller intracranial hematoma may not require surgery at all. Diagnostic testing of the patient suspected of suffering from intracranial hemorrhage include arterial blood gases and continuous oxygen saturation to assure proper gas exchange, CBC with an emphasis on RBC hemoglobin hematocrit, a coagulation profile, a basic metabolic panel including electrolytes, blood urea nitrogen, creatinine, liver function, urinalysis and urine osmolarity, and a culture of any CSF. You should know that the urinalysis and urine osmolality can help determine if the patient has signs and symptoms consistent with increased intracranial pressure. Further, diagnosis of IC bleed can be confirmed with computerized tomography of the head, skull x-rays, magnetic resonance imaging. An EEG can determine if there is any seizures associated with the injury, and cerebral blood flow studies and cerebral arteriography can determine if there are any deviations in blood flow to the neurons. Complications are very serious and can include very deadly hydrocephalus and brain herniation. Since a frequent cause of traumatic brain injury is motor vehicle accidents, there are priority intervention that the healthcare team needs to instigate when the patient arrives in ER. This assessment is not limited to a neurological assessment because if there is enough force to injure the brain, that means that there is going to be enough force to injure other structures, including but not limited to the cervical spine, the thorax, and the abdomen. These may require surgical interventions, and post-surgical care of these surgical interventions may include brain surgery, cardiovascular surgery, pulmonary surgery, or even exploratory laparotomy. With any traumatic brain injury, the changes to the neurological status of your patient is devastating. There will be long-term changes. So your discharge teaching must include the fact that there will be changes in mentation, cognition, behavior, etc. So remember, the non-surgical management of a head injury always includes assessment of the ADCs, assessment of vital signs to prevent and detect increased ICP, positioning to decrease ICP, pulmonary ventilation and management of oxygen and carbon dioxide levels, suctioning to maintain a clear airway, which may include, by the way, chest physical therapy and frequent turning. Drug therapy for the patient who is suffering from traumatic brain injury may include glucocorticoids to reduce the inflammatory process of the brain, mannitol and or furosemide, not only to reduce the amount of water on the brain and thereby reducing the space that the brain's taking up, but also to help to decrease intracranial pressure. Opioids and neuromuscular blocking agents can be used to decrease the metabolism of the brain by decreasing the stimulation, This should allow the brain cells to help recover. Other medications include anti-epileptic medications, acetaminophen and aspirin for fever control, and if there is enough damage to the brain and the neurons need to be preserved, this may indicate a barbiturate coma, where the patient is intentionally put into a very low metabolic state in order to preserve neurological cells. During the surgery, ICP monitoring devices may be placed in the patients. These may include a intraventricular catheter, or IVC, a subarachnoid screw or bolt, an epidural catheter, or a subdural catheter. A craniotomy may be performed in extreme instances of elevated intracranial pressure. Again, without the interventions, the patient is at danger for herniation and death. That does conclude this episode of the neurological series. However, stand by, because we have a couple more, and in our next episode, we will be discussing increased intracranial pressures and interventions to help reduce that complication. We'll see you then.